Good day. Now we'll speak about dental implantation. Here you can see on this picture you can see dental implant. This is design of an artificial processor support that transmits chewing pressure. Here you can see parts of implant. First of all is its intraosseous support or immersion. Second one, head intraoral superstructure, then neck element dividing the implant, and mesostructures we will join silicone gaskets. Here you can see the situation after implantation. Next photo is the insertion of former, and here you can see the final result, crown itself. And here is abutment. This part inserts into the implant, and on this abutment we can put crown. Basic principles of dental implantation. Implantation should be carried out 3 or 4 months after tooth extraction. There should be no focal chronic infection in the body. Sanitation and good hygienic condition of the teeth and oral cavity are essential rules when using implants. Minimal presence of various metals in the oral cavity and other bones. The remaining bone tissue in the area of the dentition defect should be used as much as possible. The type of implant and its design are determined by the requirements of prosthetics, anatomical conditions, and the state of the teeth antagonists. Also, we can tell that implant must not injure the surrounding tissue. The use of different metals during the manufacture of implants and the operation is unacceptable. The preparation of the bone for the implant should be carried out at the moderate speed of from 5,000 till 7,000 rotations per minute, only with a tungsten carbide burr and with intensive cooling with isotonic solution. Strong fixation and stabilization of the implant is required. There should be also no mobility of the inserted implant, which is achieved by the accuracy of the operation performed. The chewing surface of the processes, the chewing load and the load of the implant must be mutually consistent. Abutment teeth are prepared before surgery. The fit of the crowns is performed a week after the removal of the sutures. The prosthetics are finished in 3 weeks. When postponing the final prosthetics, manufacture of temporary prostheses is mandatory. Indications for the use of implants. In the absence of one tooth in the anterior region, when the adjacent teeth are intact. Second one, limited defects of 4 or more teeth. Bilateral terminal and one-sided dentition defects in the absence of 3 or more teeth. Adenomatous jaws, and especially with atrophied alveolar processes. Patients who cannot wear removable dentures due to increased sensitivity to acrylates and with a pronounced gag reflex. With diseases of the gastrointestinal tract caused by the loss of teeth and disorders of chewing food. The implantation operation is indicated for patients under the age of 55 or 60 years, but it's also possible at an older age, provided that they're in good health. Here you can see contraindications to the use of implants. First, this is absolute. Bruxism, chronic diseases, diseases of the blood-forming organs, diseases of the skeletal system affecting their regenerative capacity, diseases of the central and the peripheral nervous system, malignant tumors. Second one is relative. Periodontitis, pathological bite, unsatisfactory state of oral hygiene, precancerous diseases, metal implants in other organs, Kirchner wires, artificial joints, diseases of the temporomandibular joint. When choosing the required prosthesis and implant design, consider a condition of the dentition, the size of the dentition defect, the degree of atrophy of the alveolar process, binding height of the dentition defect, the completeness of the bone structure of the alveolar process, the position of the maxillary sinus, the pear-shaped foramen and the mandibular canal according to the X-ray image, condition of teeth, gums, oral mucosa, condition of antagonist teeth, natural and artificial, quality of available processes, galvanic phenomena, type of metal of processes and implant, hygienic condition of the oral cavity. Materials for the manufacture of implants. Titanium alloy implants are used with great success in dentistry. Usually the intraosseous part of the implant is made of commercially pure titanium VT10 class 4 due to the best mechanical properties. VT6 titanium aluminum vanadium alloy class 5 is also widely used. Dental implants are also produced from zirconium dioxide. Such implants have a cosmetic advantage, since there is no dark translucence for the mucous membrane, which sometimes appears when using implants made of titanium and alloys. However, zirconium dioxide is also integrated to a lesser extent than titanium, and is also difficult to finish in the oral cavity. In view of this, zirconium dioxide implants are not widely used in the world. Research is underway to find new biocompatible material, in particular clinical trials of titanium zirconium alloy, commercial name Roxolade, developed specifically for dental implantation, are underway. Nanostructured titanium is considered as a promising material for dental implants, due to a significant reduction in their average size of crystal grains. Its strength becomes comparable to the VT6 alloy, which allows the manufacture of smaller implants. If it was found that nanotitanium provides a better osseointegration as compared to coarse-grained titanium. Design of the intraosseous part of the implants. First, cylindrical implants. The intraosseous part of the cylindrical implants with a smooth surface has the smallest surface area and the lowest biomechanical indicators in the Schott test. Therefore, cylindrical implants must necessarily have a geometrically developed textured surface or a bioactive coating. Screw implants. They're the most common type of implant. There are quite a large number of their modifications that differ in their thread profile. Screw-shaped implants can be collapsible and non-collapsible. 1 and 2 stage have a smooth rough surface or a coating of bioactive materials. They are characterized by higher shear test rates compared to the cylindrical ones. Anti-rotation protection. Rotation of cylindrical and screw implants, they're not connected with each other or with their own teeth, can occur in the bone even after the period of bone tissue regeneration, both under the influence of chewing load or during a medical procedure. Therefore, as an essential element of the design is intraosseous part of such implants are anti-rotation locks. They can be anchors, recessors, platforms, holes, longitudinal grooves, combination of various transitional shapes, and section of the intraosseous parts of implants. Plate implants. Plate implants, it was very long ago. Plate implants can be collapsible or non-collapsible. The surface requirements for plate and cylindrical implants are the same. Plate implants must have a textured surface and or a macro relief in the form of a snake and a corrugated plate, as well as the holes for bone tissue growth. It's believed that their area should be approved intraosseous sport in the area. Combined implants. Combined implants, the intraosseous part of the implant can be combined in several forms. The most common is a combination of cylindrical plates and plate shapes. Such implants have a central part in the form of a cylinder, from which two symmetrical or asymmetrically located plates extended. These transmandibular and ramus frame implants can also be classified as combined. And here we have to speak about a very popular, about 15 years ago, types of implants. Here is ramus frame implant, this is a combination of a thin, long metal plate and its attachment points in the jaw bone tissue. Just like a plate cylindrical implant, it belongs to the intraosseous structure. Fixation inside the jaw usually occurs in three places: in the front of the center, near the incisors, in the back of the jaw, near the molars, 2 times. This design combines the positive aspects of lamellar processes and implants with R-shaped structure that have an increased stability during prosthetics. Ramus frame is used mainly for severe atrophy of the lower jaw, but still has minimal requirements for the state of the jaw. The height of the bone tissue is more than 6 millimeters, and the thickness of the alveolar ridge process in the buccal lingual direction is more than 3 millimeters. Periosteal implantation. Periosteal implantation is used for very pronounced atrophy of the lower jaw. Transmandibular implants are not placed through the mouth, but through a small incision in the chin. An accurate bracket is installed, which is then fixed with 2 sufficiently long pins in the bone, passing through it. Protruding into the oral cavity, the pins serve to fix removable dentures. The requirements for the implant are the same for the ramus frame. Disc implants. Disc implants are also installed in the case of impossibility to implant screw-shaped and cylindrical processes. Usually this is done using a progressive surgical technique of a direct placement of a disc implant. The main advantage of such an operation is the possibility of prosthetics in almost any condition of the jawbone tissue. Here you can see different types of implants. In the bottom, on the bottom, Russian letter V, you can see one of the most popular implants in the beginning of the 21st century and then the end of the 20th century. And now almost about 99.5% of all implants are like letter A. And the don't and the osseous implant, it's a post inserted through the root canal in order to restore the normal crown-root relationship and strengthen the tooth. I is made from titanium, tantalum, KHC, cobalt chromium alloy, aluminum oxide. The surface of the implant is even, but it can also be grooved. So periosteal implant, as I have already tell you, indicated with a narrow and low alveolar process. The supraosseous implant consists of the following parts: the head, the neck, and the base, in which the edge support stabilizing bands differ. And there's also a hole with fixing screw and push button lock. Here is types of variants, not types of variants of supraosseous implants. And those are supraosseous implantations not used now. Intramucosal implantation, insert implantation. Implants is placed in the thickness of the jaw mucosa. Submucosal implantation, as you see on this slide. Collapsible or non-collapsible structure. Almost all are collapsible structure. And thanks to this collapsible structure, we can do transferring the situation from the oral cavity to the situation on the oral model. Dismountable implants can differ from each other in the options for connecting components. In some, the connection of the head and the intraosseous element is carried out using cement. The rule in implants with ceramic intraosseous ports. In some implants, Bacon employ fixation and connection of the head with the intraosseous element is carried out due to the mechanical jamming of the hybrid parts. The most common screw connection. In this case, the thread can have a cylindrical in most known designs, or conical shaped radius system implants. A number of implants can have a combination of cylindrical thread and sitting cone, Schramm and Degussa Ankylos aftertouch. Abutment design. There are many designs. The abutment is a port that insert into the implant, and you put your crown on the abutment. There are many design options for implant heads. The simple structure are in the form of a cylinder or cone and the corresponding module. For connection with an intraosseous port. There are also heads of complex shape, repeating the stamp of a tooth with a shoulder processed under a crown. In addition, the heads of the implants in their upper part or on the side can have a threaded channel into which the screw fixing the prosthesis is installed. This is designed for conditionally removable prostheses. Implant heads have different taper. Angle of inclination of the sides of the support part heads from 20 to 40 degrees allows disappointing the inclination of non-parallel implants. For the implementation of prosthetics on obliquely installed implants, there are also heads supporting the part of which at the different angles, usually from 10 to 25 degrees in relation to the connection module. Stages of dental implantation. The process of dental implantation is carried out in several stages: preparatory, surgical, and orthopedic. Preparatory stage. Preparatory patient for dental implantation is a crucial stage in the successful operation and prevention of postoperative complications. At this stage, anamnesis is collected, an assessment of the state of the oral cavity and general condition of the body is carried out. And an equally important study before implantation is a computer tomography, which allowed you to assess the condition for the tissues of the maxillofacial region. Then in some cases, examination and treatment of the other organs might be required to prepare the operation. And also you can need to make a correction in these organs. If necessary, the doctor will sanitize oral cavity with obligatory professional teeth cleaning. At the stage of preparation for implantation, contraindications for its implementation are determined. Making diagnostic model surgical template and VAX model, drawing up the treatment plan and concluding a contract. Surgical stage. Implantation of installation of implants can be carried out according to one or two existing methods, one stage or two stage. In one stage implantation, a non-separable implant structure is installed, the abutment of which protrudes into the oral cavity above the gum. Two-stage implantation is the more common technique. For its implementation, a collapsible implant used. Orthopedic stage. Taking casts from the dentition, dental plaster models are being made, making a bridge or dental crown. Post-operative observation. The service life of implants varies from patient to patient and varies from several years to 10 or to 25 years, depending on the state of human health, primarily on the presence of dental or systemic pathologies. It's very important for every person who decided to undergo the implantation procedure to know how that after the operation, mandatory scheduled examinations by the dentist are required, about one time per half a year. The doctor will be able to check the functionality of the implanted implant, the state of oral hygiene, signs of inflammation and rejection of the implant. In the future, an annual examination by a specialist is required, during which X-ray examines the quality and density of bone tissue. Occlusion and articulation are checked. If necessary, the patient receives advice on compliance with hygiene rules. The wear of crowns and seals covering the holes as fixing screws must be recorded. During the post-implantation period, inflammation of the tissue around the implant can be verified. With this complication, the developing inflammation causes progressive destruction of the bone tissue surrounding the implant. Here are the causes of peri-implantitis: hemorrhage after the plaque with a further separation, inaccurate technique of preparation of the bone bed, poor quality closure for a surgical wound, unsatisfactory condition of the oral cavity. Here is the clinical picture of peri-implantitis. You have on the upper slide, you can see a big part of granulation tissue. It's very, very bad. It's very, very bad for prognosis. Here also you can see clinical symptoms of peri-implantitis. Note that the large amount of plaque and calculus and visible signs of inflammations in the peri-implant mucosa. So that it's very important for you to see your patient first of all after implantation every month for 3 months, and then every half year. Mucositis. Mucositis is an inflammation of the mucous membrane in the area of the dental implant without signs of bone loss. Clinical signs similar to gingivitis. Rejection of implants. It's extremely rare because the implant material is a biological inert substance. The reason for rejection include overheating burn of the bone tissue during the operation, for example, during drilling. This leads to the formation of granulations, which prevent the implantation of the implant into the bone tissue. Another cause is osteoporosis, for example, due to a lack of blood supply. In this case, the bone tissue simply cannot grow normally around the implant. During the second stage of implantation, placement of the abutment, unscrewing the root implant with a plug. This can be in the case of violation of the implantation due to the development of rejection of peri-implantitis, when the restoration of structure of the bone tissue around the implant is improved. Pushing the implant into the maxillary sinus. It's a very serious mistake. It occurs both in case of non-observance of the implant installation technology and in the presence of violations of bone tissue restoration. In this case, the implant is removed. Bone formation above the root implant easily corrected when installing the hidden abutment by removing the build-up. Prosthetic error that leads to complications. Incorrect crown configuration, non-observance of the bottom of the crown of that one side in relation to the axis of the implant, which leads to untwisting or fracture of the abutment. Here you can see the fracture. Poorly fixed abutment of the implant. There is gap between the implant and the abutment, and it can lead to fracture too. Poorly fixed prosthesis of the implant. Improperly formed fissure-tubercular contact between the prosthesis fixed on the implant and the antagonist teeth. Traumatic occlusion, so-called. Rigid simultaneous fixation of the prosthesis on the mobile teeth and the implants. Incorrect planning of the size of the crown and the console, which leads to unilateral overload of the implant. And also, then, poor polishing of the crown garland fixed in the implant. So it's a few words about implantation. We shall tell more about it on our classrooms. So bye bye.